It's a real pleasure to come here this afternoon. Thank you for the invitation to come. And first of all, I'd like to congratulate the network for bringing and doing research to inform and to get palliative care into homes throughout Ireland, and for having this community-based palliative care as the topic today. I'm an emeritus professor. That means I retired quite recently from Edinburgh University. You can see the website there. So Kirsty Boyd continues to lead that group there. I used to be a GP. In fact, I was a GP for 30 years, first 20 in health needs assessment. And the last 20 years, I've been having an interest in developing palliative care as a general practitioner. So we'll go to the next slide then, and just talking about, and I'd like to just reflect a bit about community-based palliative care. And this is really what I'm hoping we'll do just over the next, say, half an hour. First, I'd like to share the vision and a sort of framework that we used as an individual, as a group, so that we could actually understand what we were trying to embark or embrace in palliative care. Having shared that sort of idea, and we'll then have a look at some European and a global vision for a community-based palliative care. I've been asked to speak about that. We will then talk something about how to disseminate to professionals and patients and the general public about resources, touch on urgent and emergency calls out of hours, and about doing impactful research, and I touch on all metrics. And then there'll be researchers here, so I've got a slide of 10 top tips for budding researchers, and I'm going to try to go through that. It should take about 30 or 35 minutes, and I've asked for a call at 30 or 35 minutes, 5 minutes before the end, so that I can wind up and then over time for questions. So please feel free in the Q&A just to write some questions or points for discussion, because as we discuss things, that's when I really enjoy that most, because we get an opportunity to learn from each other that way. So first of all, let me just share on the next slide the potential of community-based palliative care. So that's the framework that our group have had for the last 20 years, in fact, because we say that the potential of doing palliative care in the community as a GP is that we can help people with all illnesses, not just cancer. We can help people at all times, years, not just the end of life. The third L is all dimensions of need. It's not just about pain control, but it's about all dimensions of need. And we can help in all settings, and not just hospice. And the fifth one is all dimensions. Okay, so I'm just going through the great potential of primary palliative care is that we can help people with all illnesses at all times, all dimensions of need, and in all settings and in all nations. So I want you, whatever you're doing, research or clinical work, just think of this as an overall framework and sort of position where what you're currently doing and what you might do or what you'd like to do more in the future. So first of all, let's look at about all illnesses. Next slide. So over the last 15, 20 years, the concept of illness trajectories at the end of life is quite common now, and classically we know that there's the acute one of a acute decline, typically progressive cancer. The second red one here is the one of dipping of organ failure. The third is frailty. And we now know that actually the most common cause of dying is multi-morbidity or multi-mortality, sometimes call it nowadays. And so we acknowledge that, and we'll talk later about how we can conceptualize that on top of these. Next slide, please. So the little music there shows that this is the more acute decline, and it's a bit like a dance. It's a Scottish country dance, for instance, because it's short, a well-defined beginning and an end, and everyone in Scotland knows about it. And that's typically of a progressive cancer, and we've studied lung cancer, bowel cancer, and glioma, and it's like that. Next slide, please. This is the progressive decline, and it's a bit like a tango in some ways. It goes down, ups and downs, and not so many people know about it. The idea is a different dance, and so dying is different for different illnesses. Next slide, please. And that's my representative line. Gradual, lower, typically of frailty or dementia. So again, they're all different. The idea of showing that there are different trajectories, there are different groups of illnesses dying in different ways. And to say that there have been many studies showing the experience of dying of different conditions. And there's one we did in COPD, and that's one we did about 10 years ago, and it's been cited many, many times. So there's been many studies on these different illnesses. Next one, please. And what we now need as we go forward in the next 10, 20 years is not just more information about how people live and die with these progressive illnesses, but planning or intervention studies to do it. And there's one that I did with a cardiologist, because in each of these illnesses, we worked with specialists, and the idea of the intervention, what would it look like? And we would reckon a future care planning. So the nurses are important, as we've heard earlier today. We found that a heart failure nurse would be ideally placed with some training in palliative care to help this group of people. Next, please. And here's one in liver failure. And again, we found that the best way to possibly intervene here is to train the supportive nurse in palliative care aspects so she can deliver a palliative care approach. It's not a referral to a specialist, because really true integration of palliative care is actually in the person who's doing it. It's good having an MDT. There's no good having an MDT that says, oh, this person now needs the specialist, and it goes to the specialist. True integration is actually in the individual. So in hospital care, we need consultant teams to be integrated, and in the community, the challenge next is all the more because it is actually dealing with different types of illnesses. Next slide, please. So back a slide. Yeah. So we're now talking about all times, and this is a slide that again is very well known now. Again, it's people know that we should start palliative care earlier than later. And this paper here has been cited actually about 1,000 times now. So it's acknowledged that this is what we now need to do in primary care is how do we get early palliative care delivered? How can that work? Next, please. Because most illnesses, it's easy enough in cancer, you could say, but here's the organ failure trajectory. You can see there are these dips. So when do we start this palliative care approach? Early palliative care, well, it can be at these events because someone's physically unwell. It gets to a stage when it starts getting progressive, and then later on there's a terminal stage. So this is an earlier stage we're looking for, not just a terminal stage. Next, please. And this is a tool that's it's called the Supportive and Palliative Care Indicator tool that we generated. Kirsty Boyd and I have been doing this for a while now. You can see it's translated into many languages and used in many countries. Next, please. And this is a tool to identify someone might benefit from a palliative care approach. It's not a prognosticating tool. It's one that would identify people for a palliative care tool. There's a tool called the PIG, some of you might have heard of. It used to be called the Prognostic Indicator Guide. Kirsty Thomas called it that, but in fact we've changed it. It's the Prognostic Indicator Guide. It's when someone might benefit from this approach. And the green one here is actually one that can be used by patients. So it's not just professionals. This is how they can self-identify themselves. And that's been used in the UK and abroad. There, all these tools are at our website, and they're freely available to use. So let's look at the blue one. Next slide, please. So the first thing here is to find a time when we should probably identify people, and when someone's declining or maybe a hospital admission. It's important to find a time and trigger this approach. Next, please. And once you identify someone who's possibly has this acute decline, why are they doing it? And that's just to check and the indicator. But it's the first thing that's important. Someone's declining, they probably need more support. Let's check if they do. And the next slide. Please. And when we identify people, of course, that's with a view to doing something, to triggering care planning there. Next, please. And this tool has actually been validated in different countries. There in Spain, that's been done there. Next, please. And the tool can be used to generate an algorithm. I'll just go through this quickly, and then it can be used on a setup. And this is happening in Northern Ireland as well, whereby GPs can actually run a search on their own practice computers and identify people who might benefit from a palliative care approach. So there's different ways of identifying. They can be used by using a screening mechanism, or just knowing an instrument like the Spectre or something like that, or even a frailty index when someone might be starting to deteriorate is the idea of when we should start having this palliative care approach, or anticipatory care as we call it. Next, please. Because these are the core skills in palliative care. The identification for people for palliative care is such a main thing. It's the main thing we've been pressing on in the Scottish palliative care these last 5 or 10 years, because there's only generalists, only GPs and hospital doctors and district nurse and practice nurses that can identify people who would benefit from palliative care. Specialists don't do this. They deal with people. So it's a point. That's a skill that we really must be able to do. Otherwise, people will not access. And access to palliative care is still the #1 issue throughout the world, even in the UK. Next, please. Uncertainty. There's a disease called prognostic paralysis that I've described, where people we don't know the prognosis, therefore they don't know if they need palliative care. It's not the prognosis, it's the capacity to benefit. In fact, if it's uncertain, hey, we don't know what's going to happen. If we're good clinicians, we should make a plan A and a plan B. So uncertainty should be a trigger, in fact, for care planning rather than doing nothing. Next, please. And here is Anne Finucane, who works in our team just now. And this has just been a paper out quite recently showing, well, how are we actually doing? What would be a good outcome measure, if you want, for palliative care in the community? We need outcome measures for individual people, but we need the measure for how our practices, how our health boards, how our country's doing in this aspect. Next, please. And so there's a tool called a key information summary, and this is used in every practice throughout Scotland, where we use whatever type of software GPs are using. Every night, part of the record to set it up, part of the medical record is auto-populated, as you can see here, and then this is sent with patient's permission daily to the hospital to give them information about basic clinical things and a checklist of patient preferences and a special note, so that the ambulance and so that various people know how to help best. And because that works so well, it's another reason why the GPs love to actually start this anticipatory care planning. Say to the patient, can we give the hospital information so that if you phone them up at night, they'll know about it. Oh yes, we'd love you to do that. Well, that's anticipatory care planning, and that's how we operationalize early palliative care. Don't use the word palliative care necessarily, but we talk about anticipatory care. Next, please. And how has this happened? Well, that's nearly 10 years ago. You can see that's what's happened. 75% of people, this is people with cancer, had palliative care before they died, and this on average started 7 weeks before. Next, please. So what has happened now? We can see that more people get it before they die, and they get a key information summary. So there's not only a plan, but it gets through to the hospital, but it starts earlier, 15 weeks. So that's good. Next, please. So what's happening with organ failure? That's what was happening 8 or 9 years ago, before this big press to identify. And you can see it only started, people were diagnosed 5 or 6 years, say, with organ failure, and only got this approach later on. Next, please. Next slide. You can see now 82 weeks. So if someone's identified for palliative care, and organ failure is the trajectory that is least well done here, this is done on average 82 weeks before a death. So that is pretty early on, isn't it? Next slide, please. And with dementia, again, very few of these people were identified for palliative care before, but now, next please, in 2017, you can see that again, it's over a year. These folk are getting early anticipatory care. Their needs are being assessed holistically, and a plan is made. And you can see that big white triangle that was there before is being inhabited. People are getting proactive care from well over a year. And in this group, look, 73% have got key information summary before they die. All care homes, of course, people go to care home. Why don't we start a key information summary? It's done. So you can see it's a great progress has been made in that way. And this is happening in many countries now. So I'm saying this can actually be done. This was done through auditing a group of different practices, about 20 practices throughout the land, going into the primary care record and seeing what was being done at these times. Next, please. And you can just see, put in the triangles of the three different illness trajectories there. Why I've done this. Next, please. I'm going on because there's too detailed. You can see that this green triangle is a lot bigger than the blue, bigger than the one. And this just shows that if you're looking at a palliative care register or an anticipatory care register, there'll be a lot more people with frailty and dementia than organ failure or cancer, because this group are being cared for longer. So if you're looking at a workload or the area under the curve, the volume or the area of these triangles represents the workload for generalist anticipatory or palliative care. So is it just cancer? It most certainly isn't. I'm not saying it's all the same type of help, but we must remember if we're supporting people, this is the big, it's not the cancer, it's everything. Next, please. And this is just to briefly show that as we are talking about care planning, it's an iterative process and various different things are asked about. Resuscitation status is recorded, preferred place of care, preferred place of death, anticipatory care meds. These are recorded and put on at different times as the anticipatory care or the care plan is done in an iterative way by the primary care team. So this is, you can see the person is getting increasing care, and this is a good thing. This is a good process that's happening. This is something that we'd like to shout loudly, that we can do this in primary care. Next, please. So I've been, because identification, I believe, is so important really in the starting access to palliative care, I've gone on a wee bit there, and I've tried to say it can happen, it is happening, and these outcome indicators of how many people have been done there. So we're going on now to the third all is all dimensions. And here is a slide here showing someone with progressive lung cancer. And there's some quotations here that we've taken in studies to show how there are 4 times, these 4 dips at the bottom here. Coming to a diagnosis very uncertain, and then feeling better, getting treatment, getting back home, it's down again. So there are 4 times when typically that person would be anxious. And it's good to know this, and we shouldn't only know about the typical physical trajectories of decline at the end of life. It should be core knowledge, and it has been at Edinburgh teaching of this, next please, that there are typical end-of-life multi-dimensional trajectories, and this allows us to know what's going to happen, or to foretell. We don't know the time scale sometimes, but we can foretell, and prognosis is that, it's knowing the future. And here's what's happening then in these progressive cancers. These are the 4 dips: diagnosis, returning home, recurrence, terminal decline. These are when people are predictably anxious and also may have psychological or spiritual distress. And it's good to know that. And so at the first step onwards is when someone would benefit from a palliative care approach or anticipatory care, as we're doing. Would we call it palliative care then? Possibly not. Someone waiting for an operation for a glioma, but they are thinking about they may die, as their carers are. So we want to acknowledge that there is a lot of distress happening, and at least acknowledge to someone that they must be worried about it. Next, please. This is just to show you the typical trajectories in organ failure. And with here, you can see that at these dips of admission, hospital admission, there could well be social problems, not seen folk. They'll be worried about it all. I'm worried about the breathlessness. So again, if we're trying to prevent these things, or if we're trying to treat them and help people at home, it's not just a physical response we should be looking for. We should help people with anxiety and go ahead and plan things like that. Next, please. And this reminds us that the carers, the family carers of people with cancer who are having this helter-skelter of distress, the family carers go through the same experiences and the worries. And we interviewed such family carers in a lung cancer study. And yes, they were also going, even their physical health declined. And again, so in palliative care in the community, the carer is often a patient as well. So it's good to, I just stuck that one there to remind us about the role of the carer. Next, please. And this is what we think is the multi-dimensional trajectory of the people with the frailty or cognitive decline. And it's not just checking the physical status, often it's one of these other dimensions, or the worry is in those dimensions. Maybe worried about getting dementia or going to a care home. That can trigger a decline. So it's supporting people in those ways. It's not just sort of doing a physical monitoring as they get lower and lower. That's missing the point. Right, and this in fact is a new slide. So I mentioned about multimorbidity, and many people have got a number of illnesses. And so one way of conceptualizing the palliative care and multimorbidity is to consider the main trajectory the person is on. And in the green here, there's a physical decline happening there. You can see with different illnesses causing a dip. But say at the first dip, the person may also be anxious, or there may be social issues. So the idea of, and in the social one, there's family, friends, loneliness or healing, and then the spiritual aspects. There could be a loss of control, loss of meaning. And so I think assessing someone with multimorbidity is looking where they are physically, where they are psychologically, their net sort of physical debility due to the various illnesses they've got. Where are, what is their assessment across the needs, and at what stage have they reached in the trajectory? And having assessed them that way, we can then work out talk about what the future might hold for them and go from there. So that's a multi-dimensional paper on that. Hopefully that one will be out quite soon in a practice pointer in the BMJ. Next, please. So we've talked about all the diseases, all times, all dimensions, all settings, also very important. And care homes would be the setting that's been most neglected, I think, by researchers and clinicians, and certainly the health service in Scotland. And I've got third here, because we predict that by 2040, because we should be thinking what we're going to be doing in palliative care in another 20 years, we would predict that a third people will live and die at home, a third in care homes, and a third in hospital. And if we just extrapolate what's happening in Scotland just now, that's what we are signed up, and politicians also agree that would be a good target to aim at on balance. And so I'm working with Joe Hockley. We have a vision for a teaching and research-based care home, a centre of excellence that would be a radical change and actually help, next slide, help this come. And we've been, for instance, in the COVID time just now, Joe has been doing some supportive debriefing carers in care homes. Next, please. And this is reflective debriefing in relation to death and dying. And so it's just another way to show that we really must support staff in care homes there in all settings. And of course, that is community-based very much. A third in each of these settings, and 2 or 4% of people will probably continue and die in hospices. So palliative care in the community is important. Hospices have to support, specialists must support others, but I think support and teaching and counselling is the main role rather than individual patient care, because there aren't enough. Next, please. The fifth all, in fact, was all nations, and it's just to say that, who is our neighbour? We are in primary palliative care. Overseas, there aren't doctors, it's nurses who do palliative care, nurses and volunteers. I studied a difference of dying in Kenya, where I used to work, and dying in Edinburgh. And in Kenya, the main issue, developing countries, lack of pain relief, pain control, whereas in Edinburgh at the time, it was more me, it was an existential issue. So it's very culturally dependent, the main issues people have towards the end of life. And Africa can teach us many things about helping folk spiritually and socially. And we recruited actually about 30 primary care teams throughout Scotland, and we went out and did a project to strengthen palliative care in various African countries. And this can be done. It means a big difference in Uganda and in Africa. We needed to bring in nurse prescribing, because it's nurses who actually do this. And so that there was nurse training, and we changed the laws in Uganda so that that can be done. So there are 56 countries in Africa, and they all need palliative care, and there's a great umbrella organisation helping that. Do consider that. They are not our neighbours, but they need care even more than we do in the UK. Right, next. So we're going on to all nations, and we're still here about Europe, because there's a European Association of Palliative Care, some of you will know about, but I've been asked to talk about the toolkit. That it's a primary care reference group that I've pleasure of being the chair of that, but we get together as a kind of key primary care enthusiasts to try to take forward palliative care in the community throughout Europe. And we did a survey of various European countries. The authors are down the left here, talking about the issues of how can we better develop palliative care in the community in our different countries, in our 54 different European countries. Next, please. And that's an infographic that we did. And the idea of, if you're trying to help any country, we did this together with WONCA, that's the big GP national organization, to develop palliative care in primary care, we need four things. This is a public health view. We need policies that support that. We need policies in primary care that support palliative care. We need the education, point two. We need a service structure that's sympathetic and facilitates it, and we need medicines available. And that's the sort of the remit. If in your country, next slide, please. We've actually developed a toolkit, and it's a 4-page document here. And there's a video that goes with it in English, and there's one in French as well. It's just how this toolkit could be used by you in your country and the different steps to go ahead. Next, please. This is available online, and please, it's in various languages just now as well. And we say that have a look at it, and whether it be Ireland or whether it's be any country in Europe, form a national working group. You're already started to do that. Identify current progress and barriers, and progress these domains and evaluate the process. And within these pages, there's links, as you can see there, to, for instance, policy. What's happening in other countries that could possibly happen in your country? So there's a great way of actually going and helping different countries. This is available, so please do use that one. And there's various other videos that support it. Next, please. And integrating palliative care and symptom relief into primary care is really so much in the agenda with WHO just now. We had actually a tremendous Zoom last week with Tedros, the chief executive in WHO, about palliative care and COVID and primary care, and he is so supportive. This is the time to integrate palliative care into primary care for those in all countries throughout the world. Next. Just looking at the time. Oh, we're doing okay. Palliative care, should it be rebranded? The question here is, how do you make this approach acceptable? In Scotland, I've hinted that we call it anticipatory care. I don't know what you do there, but we had a couple of editorials in the BMJ last year, and we were equivocal about should it be branded or should we actually use the word and explain what it meant, but it puts off so many people. But we thought more important than that rather academic debate about naming, we just have to actually support its implementation in the primary care workforce, was the most way ahead. And these are BMJ readers. They said 89% of the readers, generalists, said that's the way ahead for primary care. Next, please. So I'm just going to mention very quickly about an out-of-hours study that we recently did throughout this in Scotland using large national Scottish data sets. So here's something slightly different. Next, please. And this paper actually just came out last week. So it's new. We're just about to put a press release on it. But what we did was we looked at everyone who died in Scotland in 2017. And we looked at that because I knew that most people would have had palliative care needs. There were 50,000 people who died, but most wouldn't have been recognised. And we were amazed to find out that in 1 year in Scotland, there were 500,000 episodes of services delivered to people in their last year of life, all done in quite a rushed way. That's more than's been documented before. And we looked at the 5 services. It's phoning up the NHS 24, the zip line. That's the first one. Then there's the GP out of hours. Then there's the ambulance. Then there's A&E. And then there's acute admissions. And we saw a lot of that is being used by people in their last year of life. Probably didn't get a palliative care approach in these very urgent times. But it was a great lost opportunity, I think, possibly, for that. And so if we're talking about palliative care in the last year of life, a lot of it is unscheduled care, or urgent care, or emergency care. And so that's where we really must integrate a palliative care approach, I would suggest, in there. Because we know in this study that different people with different illness trajectories sought care in different ways. People acutely breathless with heart failure would tend to phone up for an ambulance and be admitted to hospital because they couldn't get out-of-hours care within an hour. They were wanting acute support. And so we actually need more. Next slide, please. And we've done, you can look at this paper if you would like to. You can see this is how care began out of these people, and how these are the sites they began and it finished at the end. Next, please. And these are things called continuous unscheduled gradual pathways. This is a novel sort of thing to do. So these are like care pathways, but unscheduled care pathways. So someone maybe phones up out of hours, this person with NO, the brown one there. So they phone up and that is dealt with in a primary care out of hours and stops there. And you can see that most calls are actually started and finished in primary care out of hours, and very few go through to the ambulance or upstream or are admitted. Next, please. But you can see, if you're looking at the economics of the costs of unscheduled care for people in the last year of life, much bigger costs in hospital, A&E, than in the GP out of hours, 4 million, or NHS 24. And so a little cost transfer from primary care to secondary care would be a very effective way, I would put it, of a high value, low cost way and preventing of admissions. Next, please. So that was just something on out of hours, an angle, a slightly unusual angle we've taken in Scotland. I know you've done a lot of work in those ways. So we're just a couple of other things maybe to discuss. So effective research and advocacy in primary care. So we would be pleased to say, with great support from Marie Curie and their policy, that we've managed to actually impact on carers legislation so that people who are carers of any terminal illness can get fast track for benefits. We've influenced Social Security. This is by our research, having meetings. We've actually managed to have a research forum, we called it in Scotland, in the last strategic plan, whereby we meet with clinicians and also with politicians, and then so that they actually understand where we're at, and we give them briefings, and then they go and they actually manage to change laws. So it's a tremendously great thing to happen, and we're very grateful to Marie Curie and the various press offices to facilitate that. Some of the research we've now got, GPs in Scotland are funded for providing early palliative care, calling it anticipatory care, and then that is extra payments that they are getting to forward that one as well. Not a lot of money, but just enough to show that it's being valued. We're now integrating most of what we've been talking about, these illness trajectories, into various medicine and nursing training schools. And we've got these care frameworks of identifying, assessing in Plamlish being operationalized so that they are systematically there. And we're also trying to engage the public with the various videos, Living and Dying Well, and even Strictly Come Dying. I'm suggesting we should have a TV show, because if we know how to dance, people dance better. If we know how to die, maybe that could work. Next, please. So on the theme of disseminating ideas, I was interested to hear that Peter May in Dublin there had done some work with altmetrics, which is I suppose an element, a level of interest that various publications get in social media. And so we looked at what are the top 10 palliative care articles just now, because it's interesting to know if we're trying to do research, to get them to. And the first one was Temel et al., early palliative care for metastatic non-cell. Now, maybe that isn't a surprise to myself, and maybe I'm just going to look at the top 10. It was a very important study, and it's just, how do we look at research studies? Well, that's a really good study. Although I have one problem with it, is that the intervention of this study was of specialist palliative care at the same time as regular review by the oncologist. So first of all, it was specialist, and I would say, well, actually, in that category, possibly a generalist palliative care could be, if you want, tried first, and then specialist if required. And I actually tried to do such a study, but didn't get funded because they wanted a study with specialist palliative care. And so it's a good study, and it really highlights the great benefit of palliative care, but the angle of generalist against specialist wasn't really clear. And it really, in some ways, suggested that palliative care is specialist palliative care. And we could just glance down. By the way, all of these 10, how many out of these 10 papers were actually in a palliative care publication? Answer is 0. So if we are wanting our palliative care papers read more broadly or in social media, we should possibly put them in wider read journals or with maybe higher impact factors. Of course, it depends who we're trying to reach. If we're trying to reach generalists about primary palliative care, it has to be in these outer general papers largely, I would suggest. Partly why the palliative medicine or palliative care papers aren't in it so much is that we're not very good actually at doing infographics or actually having a knowledge exchange editor. And if we did have, we could easily get them up like that. I have a son actually who's a sports medicine doctor, and he's into infographics. And he had a paper recently in the British Journal of Sports Medicine. Actually, he got a huge infographic, a huge altmetric by having an infographic and a video as well. Embedding a video into a paper also is a good idea. I did one on these multidimensional trajectories on YouTube, and it's had 30,000 views of people reading it, actually, hopefully, so that they can understand the rationale for multidimensional support in palliative care. So thinking of making things more attractive is a way if we are wanting to get our research read broadly. It's a different type of impact than changing laws and actually changing practice, but it's something to consider. And I'm just getting towards our final slide now. So this is palliative care research, 10 top tips for impact. So we'll just take this slide, I'll just go down it briefly. So if you're thinking about palliative care research or you're early on, I think it's good to find an issue that you're passionate about. And to me, it was inequalities in healthcare. And then find the best method to highlight the issue. And you'd think, well, I'd probably be a quantitative person because inequalities is that. But I thought we'd interview people in different countries and would highlight, or with different illnesses, that would highlight the issue. And so I then learned that sort of method. I create or join a team to work with. So it's good to actually work with people. Like if you're thinking of doing a PhD, find the best person in the world you think who could actually help or would really understand, help you do what you want to do, and go there, not just the sort of nearest person. Get sort of an expert, or maybe get 2 people with different backgrounds to supplement or complement if you're doing a study. Could be an economist in palliative care or whatever, or nursing and a qualitative researcher. These multidisciplinary things are good. And then display the findings clearly and graphically in whatever you're doing. And then selecting the best journal according to whom you want to influence, possibly. So be thoughtful about that and thinking who's going to review your paper. And then having done the research, don't finish there. Write analysis or editorials to explain, what it's all about. Then chapters into textbooks. Speak at conferences, possibly. And then hold special dissemination knowledge transfer events. This is going the extra mile, but these are really, really important. Otherwise, it's not worth doing research unless we get it to change things. And these can be very satisfying, talking with clinicians, getting feedback on findings before presenting them. And then collaborate with friends and just go out front, boldly lead nationally and internationally. In primary care, I met with a friend in Australia who was also very interested in this, a GP, and he said, why don't we start an international network for palliative care in the community? And said, yes, let's do that. And let's call it the International Network of Primary Palliative Care. And we did that. And just being bold and doing things. And we actually ended up advising WHO on this aspect because we were the only really international body on this aspect. So be bold. Educate undergraduates, clinicians creatively, and then reach the public and patients directly on whatever. It's great fun. Create videos. And I've had great joy with a geriatrician as we've been doing some conferences, creating a video about multi-mortality. Next, please. We're just getting there. That's some things at our website. Feel free to visit. These slides will be available and they've got links on them. So feel free to dip in there and to the European Association Palliative Care, where they have got a lot of these resources in different languages. The 5 main European languages are catered for there. Next, please. And this is just a video I'd like to plug. We haven't time to show it, but this is as it's there, and that's a 4-minute video on palliative care, learning from illness trajectories of decline and to triggering approach. Next, please. So this is just the back. So hopefully we've had a time to chat and reflect a bit about palliative care. I've explained what we've been up to in primary palliative care the last 20 years, but 2040 is another 20 years. So I think we're just maybe halfway there. So I'm wanting you guys to inhabit the land and get on and do greater things with the gospel of palliative care so people can not suffer as much. Have a European, global vision even. We must disseminate professionals. We've talked about out of hours. I think out of hours all times doesn't just mean early and late, but it means all hours. You know, why is there so little primary care provision out of hours, but there's a lot more GPs there in hours? So there's a real issue about out of hours, I think, and care homes, you know, are big sort of subject matters we must address. Thinking about research, why do it, who we want to impact, and that was some top tips. So I think I'll finish there.